I think we should get started. Okay. Good evening and welcome, everyone. Today we are having an interactive session about mental health and social work. We are very fortunate to have a wonderful and experienced panel of mental health social workers to deliver this session. This session is moderated by our member, Mrs. Jaya Pradeep, who is a close associate of MASWO's initiatives. Jay has been an integral part of our COVID-19 crisis response team, and she was one of the leads in the employment-related response during the crisis time. Jay responded to numerous calls from the community and provided timely information regarding CERB and EI. Her contribution was very valuable. Jay completed MSW from Yashwanti Rao Institute of Social Sciences, Pune. She has over 18 years of social work experience working with diverse population, such as children, youth, seniors, and families in various settings like Ontario Works, Community Health Center, school, hospital, and child welfare. Currently, she works at Toronto Employment and Social Services for past 4 years as a caseworker. She's also an alumni of Ryerson University ISW program. I welcome Jaya to the session and she will take this forward. Jaya, we can't hear. Can you increase the volume?
Sorry about that. Can you hear me now? Is it okay?
Yeah, still it's slow.
Better now, but still slow.
Sorry about that. How about now?
Yeah, it's okay.
Okay, thanks. Thank you, Joji, for introducing me and giving me an opportunity to combat today's session. I'm extremely glad to be a part of it. Next slide, please. Okay, the topic today is, land acknowledgement. We would like to begin by acknowledging that the land on which we gather is the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Scugog, Hiawatha, and the Alderable First Nation. Good evening, everyone. As you are all aware that mental health is an equally important aspect like our physical health, which helps an individual to function fully and thereby leading a successful life. It's always good to keep us updated with the information on mental health, and as such, I would like to take this opportunity to welcome all of you to this informative webinar where experts from mental health will be covering an overview on mental health and mental disorders, mental health stigma, legislation, crisis assessment and intervention, recovery-oriented practice, community mental health, and critical skills for social workers in mental health setting. Today, to conduct this session, we do have very distinguished and efficient speakers who are well qualified and experienced professionals from mental health, working in diverse mental health settings. My role as of today is to introduce these distinguished speakers and moderate today's session. We will be handling the question answers at the end of the session based on the time allotted to us. And if we are unable to go through all of your queries considering the time, or you do have still further questions for which clarifications are required, please feel free to email your concerns to our MASWO email, maswocanada@gmail.com. To begin with, I would like to introduce Mr. Manoj Edamana. Manoj has completed his MSW from Nagpur University and Diploma in Counseling from UK. He has worked for 5 years with CASA, 2 years in child protection in UK, 5 years in providing psychotherapy for children and families, and for the past 7 years working in inpatient psychiatry as social worker cum therapist with Niagara Health System. In total, he has more than 18 years of experience in mental health. He is also currently president of Niagara Malayali Association and engages in different community programs. Manoj will be talking today on mental health. Let me now invite Manoj to start off with his session. Welcome, Manoj.
Thank you, Jay, for introducing me to the participants. And good evening to all of you. Let me start the session by asking a question. Of course, I'm not expecting the answer. Keep the answers to yourself at this point of time. So when you hear the words mental health, what is the first thing that comes to your mind? A person who is wandering on the street without taking care of himself, wearing shabby clothes, person without any aim, talking himself, or just wandering. Let's hold on to the answer for a while and move on to let us see how things would be, how we look at things. Many people use the terms mental health and mental illness interchangeably when really they mean different things. Mental health is a state of emotional, psychological, social well-being. It affects how we think, feel, and act. Mental health is a state of well-being, and we all have it. It is not just about surviving. It is about thriving, enjoying life, having a sense of purpose, and being able to manage life's highs and lows. Mental illness are described as disturbance in thoughts, feelings, and perceptions that are severe enough to affect day-to-day functioning. Poor mental health can lead to mental and physical illness. World Health Organization says mental health is a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make contribution to his or her community. Let's look into some facts in Canada. 1 in 5 Canadians experience a mental illness or addiction problem. 10% of children aged between 5 and 16 have a clinically diagnosable mental health problems. By the age of 40, 1 in 2 Canadians have or have had experienced mild or severe mental illness. 70% of mental health problems have their onset during childhood or early adolescence. Young people aged 15 to 24 are likely to experience mental illness and or substance use disorders than any other age group. Men have higher rates of addiction than women, while women have higher rates of mood and anxiety disorders. So let's look into what is mental illness. Mental illness is the reduced ability for a person to function effectively over a prolonged period of time because of significant level of distress, changes in thinking, mood or behavior, feelings of isolation, loneliness, and sadness, the feeling of being disconnected from people and activities. Mental illness can be experienced by people irrespective of age, culture, caste, religion, education background, financial status, and it is not the same as feeling distressed because of normal reaction to difficult situation and situational crisis. It is normal for a family member to grieve when they lose a family member. If it is prolonged for a long period of time, then that can be a mental health issue. The symptoms of mental illness can be mild, moderate, or severe, depending on the type of mental illness, individual and patient's environment. Now let's look into some of the contributing factors. First one, I'll start with the genetic factors. That's called the family history. And it is not necessary that if anyone in the family has a mental health problem, that will pass on to next generation. But there is a likelihood. It is just like someone has the diabetes. There is a child likelihood of the happening, passing diabetes to the next generation. There is a chance. Developmental issues. Whether the person has met all the milestones of growth or not. Environmental influences on fetus, such as expecting mom's exposure to drugs or alcohol. Living in continued stressful events such as financial problems, loved one's death or divorce, this can also contribute. Socio-economic educational factors and early life experience such as abuse or trauma. Now let's look onto some of the major mental disorders. I'll start with the most common one in mental health, that's anxiety disorders. Of course, that's my favorite one, so I'll come back later. So, mood disorders. There are two aspects in mood disorder. One is a depression, the other one is a manic or bipolar manic situation and depression. Some people may feel hypomanic for a certain period of time and then they feel crash. They don't need to have a sleep, or they feel very energetic, feeling not having sleep, and then they crash. Psychotic disorders is a state of mind in which people have trouble knowing what is real and not. Personality disorders is a disorder defined by unstable moods, behavior, and relationships. And that can easily affect the client's social, family, marital relationships. They may be struggling to maintain relationships. Concurrent disorders. Lot of mental health patients, they use alcohol or drugs to manage their emotions. Especially people with anxiety and depression, they use alcohol and marijuana or weed, other stuff. Dual diagnosis is a two diagnoses together, especially mental health and autism spectrum disorder or developmental delay. That can be high functioning autism or low functioning autism. Now let me come back to anxiety disorder. American Psychology Association defines anxiety is an emotion characterized by feelings, tension, worried thoughts, and that leads to physical changes. So anxiety is the mind and body's reaction to stressful, dangerous, or unfamiliar situations. It is a sense of uneasiness, distress, or dread you feel before a significant event. Mild level of anxiety is normal and everyone feels anxious at times. Keep in mind, mild level of anxiety is normal and everyone feels anxious at times. A certain level of anxiety helps us to stay alert and aware. Anxiety is our body's natural response to stress. It creates fight or flight response to perceived threats. Anxiety is a fear or apprehension about what is to come. Then, when is anxiety become a concern? Anxiety becomes concern when it affects your day-to-day life, when you are no more able to function in a normal way. So anxiety disorder is a persistent and excessive fear of specific object or a situation. Now let's look into some of the major anxiety disorders. The generalized anxiety or panic attack, agoraphobia, specific phobia disorder, social anxiety, OCD, PTSD, and so on. So some of the tools we use is exposure therapy, cognitive behavior therapy, and so on. So we are not going to look into that one in detail. Okay. So let's move on to social stigma. Social stigma, according to CAMH, Center for Addiction and Mental Health, stigma refers to negative attitudes and negative behavior towards people with mental health problems. Stigma is a negative stereotype and it's a discrimination or unfair leads to unfair treatment. Stigma may tend people to avoid or delay treatment. Stigma and discrimination can make mental health issues worse and harder to recover. And it prevents accessing services. Many people may feel comfortable to speak about their physical problems over mental illness. And stigma among South Asian community is more related to shame and embarrassment and false belief. And it is always referred in the past as a demon's mark, or it is the family or the person is possessed by demon, or his or her forefathers had immoral life, and that the God has punished them now. So destigmatizing mental illness is like any other illness. Mental health is preventable, provided you have a good and a healthy lifestyle and support system. It could be mild or moderate or severe, could affect anyone, is treatable and recoverable. Coming to diagnosis and treatment, I work in hospital. So let me just put this way. When a client comes to the hospital, we use the diagnostic statistical manual for mental health disorders called DSM-5 for giving diagnosis. So the starting of admission is a physical examination, lab test, and then that leads to a full psychiatric assessment by care team led by psychiatrists. And it's always a multidisciplinary function. Mental health professionals will assess presenting symptoms, thoughts, feelings, and behavior. In certain cases, accurate diagnosis may not be possible, but treatment is given to manage symptoms. The diagnosis is given basing on the symptoms. And DSM-5 is the underlying principle for giving diagnosis. The treatment depends on the type of mental illness and its severity and what works for the best for the person. In many cases, a combination of treatment works best. So the first aim would be, the treatment goal would be psychiatric stabilization, and for which pharmacological therapy is used. That's oral medications and sometimes injections. Luckily in Canada, the mental health has progressed so well, and some injection can be given just for 1 month, and certain injections, with one injection, the patient can maintain the health for up to 3 months. Once the patient is stable, then therapies are offered like individual and group therapies using motivational interviews, cognitive behavior therapies, or dialectical behavior therapy, or brief solution focused therapy, and so on. The next one is ECT and TMS, electroconvulsive therapy or transcranial magnetic stimulation for treatment-resistant depression and even for dementia too. Most mental illness can be effectively treated by health professionals and community-based services. However, people may need hospitalizations to stabilize their symptoms. Once the patient is stable, then the next level of treatment is offered like a support group, complementary and alternative medicines, self-help plan, peer support, and so on. If you experience signs of mental illness, it is important that you seek help as soon as possible. So what we can do for improving mental illness? Take care of yourself, treat yourself with kindness and respect, avoid self-criticism, adopt a better lifestyle, learn to relax, learn to live in the moment, that's called mindfulness, set smart life goals, associate with the positive people, develop more social friends than social media people, and ask for help when needed. Thank you so much.
Wow, that was indeed a great session, Manoj. It really helped me to refresh my knowledge on mental health, and I'm sure it was equally important for our audience as well. Thank you so much, Manoj, for your presentation. Moving on to our next session, I would like to introduce our next speaker. She is Ajmol Mohan, who is a registered social worker. She has completed her master's in social work from Rajgiri College of Social Sciences and has completed her MPhil from NIMHANS, Bangalore. She has over 22 years of experience in mental health sector and specifically 15 years in crisis intervention. She did work at St. John's Medical College, Bangalore, Dufferin Child and Family Services, Orangeville, and currently working at BCH, William Osler Health System since 2006, currently stationed at Headwaters Healthcare Center since October 2010. She also works as functional holistic health coach, helping women find the underlying root causes to unhealthy weight gain and chronic health condition. Crisis intervention is a competency that a social worker requires, especially in the context of mental health. A very interesting topic to be aware of. I will now invite Ajmol to start off with her presentation on crisis intervention and strategies involved. Welcome, Ajmol.
Thank you, Jaya, for the kind introduction. Thank you, Masa, and good evening, everybody. I'm going to be talking about crisis intervention, specifically how we do mental health crisis assessment in a hospital setting. So what is crisis? Crisis is a state of imbalance, usually due to a specific event or situation that contributes to a significant problem which cannot be resolved by familiar strategies. Crisis reaction is an acute stage that follows the event, characterized by helplessness, confusion, anxiety, shock, disbelief, anger, depression, suicidal, homicidal ideas, and so on. So the presentation can vary from being incoherent, disorganized, agitated, volatile, calm, subdued, withdrawn, or apathetic. However, it's during this period the individual is often most willing to seek help. Hence, if you happen to see any of these sudden changes from the previous functioning in any of your family members, it needs to be taken seriously, especially if someone is mentioning about death, suicidal ideas, researching methods to end life, texting goodbye messages to others, etc. Mental health crisis is any situation in which a person's actions, feelings, and behaviors can lead to them hurting themselves or others, or put them at risk of being unable to care for self or function in a community in a healthy manner. So let's look at some of the common mental health crisis examples. Any suicidal or homicidal attempt, for example, overdose, attempting to hang, cutting, I'm not talking about the superficial cutting here, cutting deep to end life, attempting to shoot, severe depressive symptoms, acute relapse of any major mental illnesses, that is active psychosis going on, acute first episode psychosis with or without substance use, acute substance withdrawal symptoms, even though this is a medical crisis called delirium, it's still a crisis. It is actually a medical fatal condition if help is not given. Acute grief, a death of a family member or divorce, any situational crisis, a death of a pet, sexual or physical abuse, acute uncontrolled behavioral issues, parent-child conflict, or any conflict leading to violence. An important factor to understand about an acute crisis, it's very unique to an individual. Crisis for one person is not a crisis for another. So it will depend on many factors like personality, coping skills, past experiences, support system, emotional intelligence of a person, and so on. So this needs to be factored in while doing the assessment and recommendations of the situation. So mental health crisis intervention is provided to intervene the acute crisis to reduce risk factors, thereby helping the individual cope with the situation in a healthy manner. These interventions are provided in ER as well as in the community by some organizations, example, mobile crisis, to help those who are experiencing crisis. However, those who are acutely ill and having suicidal or homicidal ideations will be brought to ER for assessment. Mental health crisis assessment. This is a structured, comprehensive professional assessment carried out by mental health professionals, mainly in hospital ER, to assess the safety of the patients to return home. Let's go into the details. Usually the referral of a patient is mainly from triage before or after ER physician sees a patient. You do have to pay attention to who sent this patient to ER and why, name of the agency, GP or anyone else. How did the patient arrive in ER and with whom? Is there a Form 1 or Form 2 in place? Form 1 is an application by a physician, usually a GP, for a person to undergo psychiatric assessment to determine whether the person needs to be admitted for further care in a psychiatric facility as an involuntary or voluntary patient, or if they could be safely discharged to the community with resources. Form 2 is used in the similar conditions as Form 1, but issued by court or justice of peace. Anyone who is concerned of a patient's well-being can approach the court for Form 2, and patient can be brought to ER voluntarily or involuntarily for an evaluation by a physician who will decide if the patient needs to be placed on a Form 1 for further assessment. Mental health crisis assessment is often required in both situations. Patient is usually brought to ER by police on these occasions. So you do want to find out what is the presenting problem, why this is a crisis. So you do want to isolate the crisis. For example, if someone is feeling depressed for 2 years, that's not a crisis. So the important factor, if and why they are in ER right now and what has changed from their baseline functioning. Are they talking about suicide now? Was there any precipitating event? Any situational crisis that's making this person behave differently or worse? What does the client say the problem? Is it different from the referral source? You have to collect all collateral history that's available to you from every sources. And next is the psychiatric history. Collect any relevant past psychiatric treatment and diagnosis, if any admissions or details, if so, any previous suicidal attempts and details, if there is, lethality and intentionality of those attempt and treatment details, any current treatment involvement, diagnosis, extent of involvement, treatment compliance, previous experience with counseling, is it positive or negative, family history of any mental illness and relevant details, if there is, list of current medications. You do have to get a good medical history relevant to the presenting problem and list of medications as well. So substance abuse history is taken in detailed account of alcohol, drug or street drug use. Look for any other addictions like gambling, shopping, sex, etc. And brief psychosocial history is collected. Now, this does not intend to be an exhaustive in outlining the complete psychosocial details of a person that we usually do in social work, but what personal and family history is relevant to the current crisis. So what are some characteristics of this person? Place of birth, first language, religion, marital status, educational background, employment status and history, contact person, etc. How many people are living in the household, dynamics between these people? Has there any physical, emotional, sexual abuse in their childhood? No details, but what is relevant to the current crisis? Is there physical abuse in their current relationship? Is there any concerns of their child abuse or neglect if the person has children? What social supports does this person have? Can they call someone for help? Is their family or friends supportive of what's going on at present? So next is mental status examination. This is a psychological equivalent of a physical exam that describes the mental state and behaviors of the person being seen. So this includes both the objective observation of the clinician as well as the subjective descriptions given by the patient. So in other words, it's a structured assessment of the patient's behavior and cognitive abilities. Let's briefly look into the details. So you do want to observe appearance of the behavior. How does a person look and behave for the interview? What's their manner of relating to the interview and about the interviewer? So whether they are cooperative or uncooperative, they are dressed, they're groomed, dressed appropriately for the weather? Are they keeping eye contact? They do not want to talk to you, or they are actively participating, etc. Affect, how do they feel and look? Are they crying, anxious, restless, angry, agitated, restless? Speech, relevant or irrelevant, coherent, incoherent, look for flight of ideas, formal thought disorder. Thought, any perceptual disturbances, actively hallucinations, delusions, false belief, etc. Always look for depressive symptoms. Ask about sleep, interest, guilt, energy, concentration, appetite, psychomotor activity, and suicidal risk, which I'll be talking in detail. Is the person oriented to time, place, or person, and is he alert? Insight. What does a person believe is the problem? What role do they think they have in the situation? So next is risk assessment, suicidal and homicidal ideations. This is one of the most important factor during an assessment. So you have to find about thoughts, plans, and actions of the person in regards to suicide and homicidal ideations. Ask direct questions about these suicidal and homicidal ideations, intensity of the thoughts, how often they have these thoughts, and the ability to control these thoughts. Differentiate between passive and active ideations. Passive is, I wish I was dead. Active is like, I want to kill myself. Now, how can I kill myself? And thinking about ways. Rating scale, it's always helpful to ask your clients to rate themselves on a scale from 0 to 10. 0 being the normal, 10 what they have really planned to do, whatever suicide or homicide, to see where they are at the time of assessment. You can ask questions like, do you feel you can go on? Do you ever wish life is not worth living? Do you wish you were dead? Do you want to die? Would you do anything to end life? If so, what would you do? When would you do? What plans you have, etc. You always need to look for hopelessness, helplessness, and worthlessness. Have you made any plans to carry this out? What would stop you from doing this? Do they have children? Have they already done any preparatory acts for death, etc.? Look for any protective factors, religious beliefs that will stop them from carrying out their plan. What are their reasons for living? Concerns about impulse control, especially drinking, because this is a dangerous combination. If there is an attempt, ask questions like, who knew about their plans? Did you speak to anyone about it? Ask for detailed reconstruction of the sequence of events leading up to the attempt. Was there any aborted attempt or interrupted attempt? Did you want to die during that attempt? How do you feel that now that you haven't died? Was there, always look for command hallucinations. If they are hearing voices, asking them to do something to hurt self or somebody else, or any active psychosis going on. Do they have any access to means or weapons? Always ask about suicide as symptoms of depression and document that you asked. You can also use suicide rating scales like Columbia or checklist if necessary, so that you covered all aspects. Family history of completed suicide or attempted suicide, if so, details, or any recent death in the family or friends. Future orientation, what's their idea about where their life is going? Any aspirations about future? Are they able to comply with the safety plan, which I'll be just talking in detail. Next slide, please. Next. So be aware of the significant interpersonal stresses that may warrant about homicidal thinking. So you do want to check if there is any presence of violent behavior at the assessment, history of violent behavior, legal involvement. Are they carrying weapon? Did they have a knife at the time of police arriving, if that's a condition? Any threat, any text messages, any concerns expressed by family or anybody else, any other evidences, any relapse of major mental illnesses, that means active psychosis going on, history of concurrent disorder or substance use. So once you collected all these details, now you need to formulate your case. So this is the impression that you're making. So this is a summary of all the above information. What are the problem, why they have occurred? What are the contributing factors to crisis? Does it flow logically from above information? For example, so you say something like 30-year-old female presenting to ER with thoughts of hanging self, with 2 previous history of depressive episodes treated under the care of psychiatrist, blah, blah, blah. Currently having active plan to hang themselves, made some preparations, unable to comply for safety. So then you do recommend what you're recommending. Next slide, please. So what are you recommending? So you, in this case, you're recommending for a Form 1, right? So what recommendations you are making to help the person? Does the recommendation flow logically from the above information? And what follow-up plans? Does this person need a psychiatric consult or Form 1? In this case, yes. Do they require social work interventions while in the hospital, and why? and next is disposition. So what action was taken? How was the situation stabilized? And you always suggest to return to ER if they are going home, or call crisis line. Discussion of the treatment plan with the client and with the family with consent, of course, physician and psychiatrist available. And if they are going home, then you make the referrals to the community resources, and you do document all these things on Meditech and transfer to Schedule 1 for further evaluation and treatment if the patient is placed on a Form 1. So just a bit brief about safety plan. You do not want to send anybody going home without a safety plan if they have come with some kind of risk factors. So this is a document that supports and guides someone when they are experiencing thoughts of suicide, to help them avoid state of intense suicidal crisis. So this can be written or verbal, but this person has to be able to take responsibility for their feeling, and so that they're what they would do about the feeling. So they are agreeing to take care of their own safety, so personal responsibility. So they should be able to identify the warning signs of suicide in the beginning itself. So then you help them find some activities to calm and comfort themselves, and distraction techniques, and remind themselves to the reasons for living. So I usually sometimes ask them to write it down and put all this document on the fridge or something where they can easily see. So write a name of a person, identify people that they can call, name of the person, phone number, and second, another name in case if they don't get the first name. And if they don't, then professional, or a counselor or a crisis line. And if they don't, go somewhere else they are safe, or removing the means, access, and giving away the medication to somebody else, example. And if none of these things work, go to the emergency. And if they cannot go to the emergency, then you call 911. So they agree that they are going to follow through all these things. So that's a safety plan, just briefly. That's all from me for now. Thank you.
Wow, that was an excellent session, Ajimol. It really needs an array of skills to work in mental health setting as a crisis worker, and especially to deal with a person with suicidal thought. Hats off to you. Thank you so much for covering this session for us. The session really covered a lot of information on mental health crisis, how it's been assessed in the hospital setting, risk assessment, recommendation and treatment, and finally, the safety plan that is developed to help a person in crisis. Thank you so much once again. Moving on to our next session, let me introduce our next speaker of today's session. We do have Mr. Joe Sebastian. He has completed his MA from Kerala University and MSW from UFT. He did work in ER, medicine, oncology, and critical care. Currently working with Scarborough Health Network. His experience include 3 years in community social work, 1 year in research, and 15 years experience in mental health. Have you ever thought why recovery is important in mental health? Today, our speaker, Joe Sebastian, will be speaking on recovery-oriented social work practice. Now, I would like to invite Joe Sebastian to begin the session. Welcome, Joe.
Thank you, Jay, for the lovely introduction and your kind words. And thank you, Ajimol, for giving a very clear view of how the patient comes to the emergency, to the inpatient unit. So we have come to a situation where the patient is on the floor. We have more time now to go through the details of the admission situation, the history, and get a viable plan for a patient to go home with a discharge. So the inpatient treatment currently is focused on the recovery model of care, which is hope, empowerment, social inclusion, and independence. So patients have a hope to recover from mental illness. It's not like it's the end of the day and the end of their life. So, and empowerment, they have more independence and social inclusion. So it's a client-centered approach where the client is a leader and the treatment team are the facilitators. And it's also based on the notion that recovery is personal. It can vary from person to person. And it's a deinstitutionalization and inclusion into the community. So you might know that a long time ago, mental health asylums used to keep patients for the rest of their life, then locked up in faraway islands. You know, some of the movies like Shutter Island, or those are very good examples of mental health asylums. Now they have become shorter-term treatment centers, and the treatment is geared towards making clients independent. So they'll be linked with all the available resources in the community for a safe discharge. So the treatment settings on a regular inpatient units comprises of regular ward, which is a larger unit for patients who are manageable on the floor, and the psychiatric intensive care for more aggressive and high-risk patients with a specialized one-to-one or one-to-two care, and specialized programs in tertiary care settings like Ontario Shores or CAMH or other hospitals can include, have separate sections for different client populations like youth, seniors, forensic, or addictions. And multidisciplinary team meets daily to assess progress of each client. All the team members provide updates from the last 24 hours. And medication compliance, behaviors, normal and aggressive behavior. So all these things are taken into account, and decisions will be made on to continue the same treatment or modify the plan. So the team comprises of a multidisciplinary team, and the core team comprises of psychiatrists, social worker, and nurses. Supporting team is occupational therapists, recreational therapists, and pharmacists, supported by external team, rights advisors, and CTO coordinators, and addiction counselors, and LIN hospital care coordinators, and lawyer or a review board team if the patient needs that. Therapy measures on daily ongoing assessment by psychiatrists, most time in the morning, and frequent meeting with social workers, daily multiple contact with the nurses, group therapy sessions by the team members, psychiatrists, social work, or the other team members, and physical and social activities. Cognitive assessments done by the OT for a long-term placement or, to deem capable or incapable of putting patient on form. Consultation by other medical doctors as needed. Multi-faith spiritual care as requested. And there's also the dietitian services are also available as needed. Role of the social worker. So it's a very crucial role in comparison to other healthcare settings, mostly because psychosocial assessment is core part of the most important part of the treatment, treatment on the unit, which is what social workers are focusing on. And social workers do conduct detailed psychosocial assessment with collateral history, provide ongoing counseling as much as possible, refer or liaise with the external service providers like CMHA, COTA, Children's Aid Society, or day programs, and make referrals to tertiary care inpatient facilities like CAMH, Ontario Shores, or other addiction programs. Initiate referrals to outpatient programs, early psychosis intervention, assertive community treatment team, facilitate family or team meeting, which is very important part of social work involvement on the unit and big part of the formulation of treatment plan. The input from family or the team, external team is gathered and delivered to all the team members and work with the patient using those. And formulating a discharge plan, as it's evident, it's a very important part, discharging back to the community. Just going back to the first slide, recovery is more, team recovery philosophy is based on discharging patient back to the community as soon as possible. Social work assessment focus, psychosocial history, continue with the crisis assessment. I just want to note that, the crisis team always try to get the best information as possible, but sometimes it doesn't work. In a very busy emergency setting, sometimes it doesn't happen, or the client is not ready or not in a proper condition to give any information. So the psychosocial history assessment will continue to gather more information from the patient or from the family or other community supports. So depression, suicide, homicide risk assessments, again, a very crucial part of the treatment. And this will continue on the unit. So sometimes some people are able to mask the suicidal ideation. So they just want to come to the floor, spend 3 days and get home and then want to commit suicide. But over maybe 1 or 2 days or 3-4 days, sometimes patients change and reveal that they had intention, or sometimes other ways around, they don't have an intention, they just faked to come into the hospital. So it's an ongoing assessment, reveals whether they have any suicide or homicidal risk. And then we go into the state of the suicidality, as Ajimol said, ideation is just an ideation, or it's an intent, or it's a plan. whether there was previous attempts or recent losses like death, divorce, job, or even a pandemic. These days I see a lot of patients with a pandemic-induced psychosis or a suicidality. So those kinds of information gathering will continue. And social work also try to get the formal and informal supports, explore what are the possibilities for a patient to go back to the community. So some of them have case management like community providers, and then some of them don't have that, but they're just surviving or dependent on family, friends, or faith groups. Previous history, including admission to other facilities. Unfortunately, psychiatric patients do go shop around different hospitals. And so we go and try to get as much information as possible. And history of trauma, substance abuse, or other addictions. Financial supports, what is existing, whether they are on ESP or Ontario Works or CPPD or work disability. And also we want to look into the discharge location, which in the very beginning we start working on this. Discharge location, future needs, home versus group home, shelter, or long-term care. Possible courses on the unit. So I'm going to give you here 3 different scenarios. These are, most of the time, these are the different scenarios that patients come in and get discharged. One is the client comes in voluntarily, patient identifies himself or herself that they need some help and comes to the emerge crisis team. Helps get admitted, and they get the treatment voluntarily, no forms involved, treatment, and go home to continue with their follow-up appointments. Scenario 2 is voluntary status becomes involuntary during the course of stay on the unit, and form 3 is assigned, and the client will be asked to stay for the 14 days, and then if needed, client will move on to the next form for treatment, and during this process, the client will get rights advisor. Next one, patient. Now the scenario number 3 is client is admitted involuntarily. This is for patients who are suicidal or aggressive or not stable or has a past history of being aggressive or suicidal. People with schizophrenia a lot of the times, gets admitted on a form 1, and which is involuntary form for 72 hours, and then moves on to the form 3 and 4, both involuntary forms for different periods, which we're going to talk in a different slide. And rights advice given, and possibility for a review board meeting because of the stay continues to be longer. In some cases, patients who are not getting better and needs more treatment will be transferred to other treatment facilities like CAMH or Ontario Shores. Common mental health forms used in inpatient units. So there are different forms I'm just going to go over briefly. Form 1 is, as we both mentioned, it's for 72 hours observation period. During that time, the client will be observed and then decided whether it has to go on Form 3, which is certificate of involuntary admission, which is 14 days. And Form 4 is a certificate of renewal after Form 3. The certificate will be renewed for 1 month, and client gets rights advice. And if needed, go for a review board hearing if chooses. So Form 4, the second one is extension of the Form 4 for 2 months. And this is again, the process goes on, review board hearing if needed, but clients get a lawyer and decide whether they have to go for a review board, and then rights advice given for each month. And after 2 months, this form will be extended to 3 months and the process continues. Now, this is Form 33, which is a very important tool to get patient treated, which is when the patient is not capable of making decisions. Like the patient may say, I'm capable, but they don't make the right decisions or lack of insight. In those situations, Form 33 will be issued. And Form 33 comes with the 2 important tools, which is Form 21 to manage personal care decisions, or Form 22 not able to manage financial decisions. So second part is done by social work and then sent to public guardian trustee. CTO, community treatment order. This is a very nice, addition to the Mental Health Act. Actually, the doctor has an opportunity to extend their hands into the community to bring patient back to get treatment. So community treatment order. So Form 49 is issued to the client to inform the intention to issue or renew CTO, and the client will be legally bound to get treatment. Sometimes it's involuntary or voluntary. And then whenever everything is decided and discussed, the formulation plan, CTP will be formulated, and client will be given a form 42. CTO coordinator gets all these things arranged, and client, and if SDM is involved, client will be given a copy along with the SDM. So when the client is on CTO and discharged home or to group home or wherever he goes, and but fails to comply with the medication plan, a form 47 will be issued to the police. And the police will bring the patient back to the inpatient unit or doctor's office to get treatment. Next slide, please. So discharge plan and support. So if the client is capable of self-care, arrange to send him or her back to the home on discharge, for provide psychiatric ongoing periodic follow-up. And if not, connect with all the other community resources as needed. And Augusti is going to talk about that. So treatment on an inpatient unit, it's a balancing act. It's because, we want to get patient, give the independence and autonomy based on the recovery model of care. And then we also have to take into account the risks that the patient can create in the community or family. And we also want to provide, take into account our professional commitment to the patient and the community. So it's a very balancing act. A client's rights versus the need for treatment. The client may not know that they need treatment, but everybody else will know the treatment. So it becomes a challenge. So it becomes a bit difficult sometimes to make a decision. So client's rights versus family safety. So patients can exert their rights over family safety. So that is when the forms get involved, and then patient may be forced to stay for treatment. In some cases, clients may go home irrespective of the team's effort to, get everything ready. And I've had cases where the clients were not certifiable. The homicidal intention was the client was able to mask really very well, and the client went home and then set the house on fire. So the client died and the family died. So it's a very unfortunate case. It touches me all the time. So it's a very challenging act. And client's rights versus psychiatrist commitment. So psychiatrists go to great length to make sure that the client's rights are respected, but the treatment is given. Psychiatric commitment, even sometimes psychiatrist is very committed, but review board makes a decision, final decision, whether patient should stay or go. Patients who are going home can leave against medical advice. If they are voluntarily, they need treatment, but they're not certifiable, then the patient may make a decision whether I want to go home. So to mitigate the risk of to the team or treating team, we ask patients to sign an against medical advice. I'm not letting you go. You're making the decision. It's on you. The onus is on you. So you can go home and face with whatever you want. So they sign out and then go. So bottom line is, the client's rights advice are respected as much as possible. But again, as I spoke earlier, it becomes a very challenging situation. People want to get treatment, or we want people to get treatment, but sometimes they don't let us treat. So the community team and the family always, come up with it. Why can't the patient stay on the unit? And especially somebody has it's a new client with a new onset of illness, it becomes a big challenge to explain to the family why we can't keep the patient. So it's a very balancing act. So thank you very much, and that's all from my side.
Thanks a lot, Joe Sebastian, for an excellent presentation on recovery model practice in hospital setting. This session literally did explain in detail the role of social workers and how it's crucial in the treatment process in mental health setting. It helped us to understand the different forms that are being used in the unit, the CTO's order, etc. The Treatment Balancing Act was really impressive and very informative. Moving on to our last speaker of today's session, I would like to introduce Mr. Augusti Matthew. He has completed his master's in social work from York University, as well as has MSW from School of Social Work, Nilaya, Mangalore University. He is currently working as a social worker at East Metro, ACT, Scarborough Adult Crisis, and works as a social worker at South Lake Regional Hospital, Newmarket. Mr. Agustin Matthew has 2 years experience helping street children in Bangalore, and he has almost 15 years of experience in mental health. Most of us might have heard about community mental health practice, but like everyone, I would also like to get more information on it. We do have a right person to help us with that. Today, Agustin Matthew will be speaking on community mental health. I would like to welcome Agustin Matthew to start off with his presentation. Welcome, Agustin Matthew.
Good evening, all of you. Thank you, Jaya. I will be talking to you about community mental health. As you know, community mental health refers to delivery of mental health services in the community setting. It is providing specialized mental health services outside of the hospital setting and assisting clients in their recovery from mental illness and reintegration into their community. The goal is helping clients reach their optimum level of independent living. There are multiple mental health agencies offering various programs in the community. I am going to mention some of the main programs they are offering. Case Management Services Program. It provides intensive case management services for adults with a serious mental health illness in the community. Case managers assist people to meet their basic needs like food, shelter, finances, develop skills, and assess community resources. There is one-to-one case management is available. Employment Services Program. It provides assistance to people with a mental illness to return to the workforce. The program is funded by Human Resources Skills Development of Canada and Ontario Disability Program. Support. It supports clients to secure job placement. Job coaching focuses on providing worksite support to individuals. Mood and Psychosis Early Intervention Program. It is aiming at understanding of early signs and symptoms of psychosis and early treatment. It provides a community-based, recovery-focused, interdisciplinary clinical services. Coordinate treatment, education, support, and referrals. Mental Health Court Support Program. Works in consultation with the court, diverts people with a serious mental illness from court system to mental health and community support services. This support can be short-term or long-term. Community Treatment Order, CTO Case Management Program, works closely with the client, the CTO coordinators, and client's treatment team. Assistance provided around employment, housing, mental health, physical health, and other community living issues. Transitional Youth Program, TYP, assist a young individual to regain or maintain age-appropriate milestones and minimize the impact of mental illness on their lives. The key focuses are education, employment, and socialization with the peers. Housing services. It make arrangement with the private landlords to lease self-contained unit. We also arrange group home, shelters, rooming homes, any accommodation for the clients. Case managers coordinate with the Ontario Works and Ontario Disability Program. Some agencies provide supportive housing and intensive case management services for individuals with serious mental illness and current involvement with the criminal justice system. Housing First Intensive Case Management. It provides support to individuals who are experiencing homelessness. Assertive Community Treatment Team, the ACT team. It is a client-centered, recovery-oriented, and evidence-based mental health service delivery model. Provide a comprehensive, community-based psychiatric treatment, rehabilitation, and support to persons with a serious mental illness. The main goal is to help keep people living in their homes, in the community, rather than in the hospitals. The team is multidisciplinary, social workers, nurses, employment specialists, occupational therapists, psychiatrists, peer support specialists, addiction specialists, and case managers. Assist individuals in their activities of daily living, social skill training, employment, and they also look after their physical health needs. Helps and advocates for affordable housing. Support is intensive, and a 24-hour on-call system is available to clients. The admission criteria to ACT team is client must be 16 years of age or older, primary diagnosis of major mental health illness like schizophrenia, bipolar disorder, major depression, and recent psychiatric admissions. Some ACT team accept individuals with dual diagnosis and concurrent disorder. Social workers in the team do initial assessment, psychosocial assessment, case management, family intervention, CBT counseling, DBT counseling, coordinate care plan, and crisis intervention. Some ACT team also work with the clients who have been involved with the legal system and have been referred by Ontario Review Board. Here, I'd like to talk to you about the forensic system and mental health, how they worked. Forensic means connected to the law or the courts. Forensic mental health system is a place where the mental health system and criminal justice system meet. If someone is charged with an offense, the person will be taken to jail or detention center. If the person has serious mental illness, the judge may ask for a forensic assessment. The person will be sent to psychiatric hospital for a treatment. The treatment can be 15 days or 2 months. This assessment is to find out whether individual is fit to stand trial or whether individual is criminally responsible for his or her actions. When the court finds an individual not criminally responsible because of the mental illness, he or she is placed under the authority of ORV. He or she must follow the orders given by ORV the same way that he or she must follow the orders given by a judge in a criminal court. Ontario Review Board is a quasi-judicial authority that reviews disposition orders for NCR clients. ORB consists of judges, lawyers, psychiatrists, psychologists, and a public member, usually 5 members, not less than 3. ORB hearing held annually to review dispositions. It will consider the need to protect public safety, mental conditions of the accused, reintegration of the accused into the community. The dispositions are 3 types. The first one is detention order. It requires the person to be detained at a psychiatric facility. They could live in the community in a place approved by ORV and treatment team to monitor him or her. Second type of disposition is conditional discharge. The individual is no longer required to live in the mental health facility. Permission is given to live in the community, subject to certain conditions. Absolute discharge. Criminal Court of Canada says the ORB must grant an individual an absolute discharge if he or she is not a significant threat to the safety of the public. ORB will give the person an absolute discharge and order is released when NCR status is over and he or she is no longer under ORB. Remember, the purpose of the ORB, the forensic system and mental health, is not to punish the individual because of the crime and mental illness. It is to support the individual to live in the community a meaningful life. So I was also asked about to talk about family support, caregiver support. As you all know, if you have a family member having mental illness, it is very stressful. It is important. It is very important. The family has a very important role to play to help this person to recover, work towards their goal, and stay well. I'd like to give you some suggestions. If you see a family member exhibiting any mental health system, I'm not going to talk about the symptoms of mental illness that already is talked about. Encourage the person to seek help. If person is suffering from mental illness, it is natural. We all feel different emotions and accept that. Educate yourself. If someone in the family is diagnosed with mental illness, please educate yourself about the diagnosis, what are the medications available, what are the treatment and support system available in the community. Stay connected to other family members and friends. It's very important, a support system in place. To connect with your family members, and you think whoever can help you, please connect with them. Join a support group where you can share and learn from others. Seek help for yourself. If needed, seek counseling for your entire family. Please don't think that seeking for help is a weakness. If you seek for help, it is your strength. You're caring for yourself, you're caring for the family member. I would like to also talk to you about if some crisis happens in the family because of the mental illness. If you think that this person is dangerous to himself or herself or others, please call 911. Police can take the individual under Mental Health Act to the nearest hospital emergency for a psychiatric evaluation. If this person is suffering from mental illness and not danger to himself or herself, still you think that this person need for a psychiatric evaluation, you could go to the family doctors of the individual and ask for Form 1, present your concerns and ask for Form 1 and take this Form 1 to nearest police station, and police can take this individual to the nearest hospital emergency for an evaluation. Suppose family doctor is not willing to issue Form 1, still you are concerned about the family member. You could go to the court and meet with Justice of Peace, present your concerns about this individual, and Justice of Peace, if convinced, she or he will issue Form 2, take this Form 2 to the nearest police station, and police can take under Mental Health Act this individual to the nearest hospital for a psychiatric evaluation. So I have the next two slides I have included some of the mainstream mental health agencies for your reference. I also included some free counseling places where people can access for counseling. As you know, because of the COVID-19, a lot of people are undergoing a lot of anxiety about your health, about your finances, about their future, and about their children. So it is important to get help. It is important to look after your physical health, look after your mental health. I would like to conclude my presentation saying that mental health is as equally important as the physical health. Without mental health, no physical health. Thank you.
Thank you so much for such a wonderful session, Agustin Matthew. The session really covered on programs offered by Community Mental Health, helped us to understand what ACT is, what ORB is, what are the support system you can depend on, especially the importance of family in the recovery process, and all the updates and the resources that you have shared on mental health. After listening to this fabulous session, don't you all think that we are missing something? Definitely, you all would be wondering what are the skills required to work in a mental health setting. Our speaker, Ms. Ajimol Mohan, will be presenting on the competencies required for you to work in a mental health setting. Ajimol, over to you again.
Thank you, Jaya. So you do need to have a Master's of Social Work and registration and membership in good standing with College of Social Work. Some community organizations will employ BSW graduates as well. You do have to have knowledge about psychiatric disorders, clinical experience doing mental status examination. The skills include empathy, active listening, observation and assessment, decision-making, client rapport, teamwork, organization, healthy professional boundaries, and strong work ethics. So you do need to have knowledge about Mental Health Act, Healthcare Consent Act, Personal Health Information and Protection Act, Substitute Decision Act, etc. So you do have to have skills in mental health assessments and crisis intervention, and skills in responding to a mental health emergency. Next. And you need to have good awareness on community mental health resources, recognizing the link between mental illness and addiction, ability to demonstrate anti-racism approach, ability to work with diverse community, and knowledge of cognitive behavioral therapy, dialectical behavioral therapy, brief solution-focused therapy, trauma-informed therapy, and substance abuse counseling. And specifically for crisis, one needs to be comfortable with working in a very fast-paced environment and working totally independently, have critical thinking, ability to prioritize, and a detailed knowledge about risk assessment, safety, and crisis plans. Thank you.
Thank you, Ajimol, again to help us understand the education and skills required to start a career in mental health setting. Before moving on to the question answer session, I would like to take the opportunity to thank all our speakers once again for devoting their precious time and delivering such an excellent presentation on mental health. I would also like to thank our audience for their participation. Next, I would like to express a sincere gratitude to Mr. Sunil Sebastian, Realtor from Home Life, and Rishani Vetuvel from Vetuvel Law for supporting and power in the mental health and social work webinar session organized by MASWO in Ontario. Thank you, Mr. Sunil and Rishani. And finally, the MASWO team, especially because without their hard work, dedication, and enthusiasm, this would have not been implemented. Thank you again. Let us move to the question answer sessions. What are the measures that can be taken to reduce stigma about mental illness? I believe this is for Manoj Edamana. Manoj, can you hear me?
Well, this question is a very relevant one. And that's what we all need to think about. And the whole world is looking to and have been trying to address this issue for a long time. Of course, we have made a huge progress. However, let me give you some tips. What are the steps we have taken? When I was working with the Pastor, we started a program called Anti-Stigma program in school levels, both Catholic and public schools, and that worked very well. And that's still going on. That is the purpose, is to improve the knowledge and increase awareness in the community. Earlier I mentioned that it's a very common that people have mental health issues. And there's a chance that 1 out of 5 Canadians have mental health issues. So it is not a very uncommon thing. So we need to accept that one, and we need to accept and then to move on and seek help when it's needed. Remember that many people experience mental illness, that you are not alone in your journey. Then the next one is to speak out against stigma. The more we speak out, more we publish our articles, the more we go to the public, people become more aware and they accept that mental health is a part of our life. And the most important one is don't equate yourself with mental illness. I have heard so many times people are saying, I am schizophrenic. No, you have schizophrenia, but you are not schizophrenic. You are not bipolar. You have bipolar. So we should be able to distinguish between the illness and the person. And the last one, I would say, don't isolate yourself. Seek out, talk to people, get help, get the treatment. And that's the way we can reduce stigma in the society. Thank you.
Thank you, Manoj, for sharing your thoughts. The next question is for Ajimol. What are the challenges you face as a crisis worker?
Thank you, Jaya. Crisis worker position can be quite challenging in many ways, even though it is exciting as well. It is a very fast-paced environment. So you're seeing the patients in acute crisis always. So the presentation can be very different from their regular demeanor. And crisis assessment is here and now process. So it can be challenging to isolate the recommendations to intervene the acute crisis, especially when you get a patient with ongoing multiple challenges. And you also can be challenged by a family member or a caseworker from the community, since there can be expectations to resolve the person's entire life issue, which is not appropriate. And many of the things can be done and should be dealt in the community itself. So emergency assessment is to assess the safety of the person going home. So it can be challenging to prioritize your work, especially when you walk into an ER with many patients waiting from previous night or weekend. So you do have to help the ER with beds. So at times you have to see less severe patients so that they can be discharged with some safety plan and the beds can be available for other patients. Another thing is that you only get 45 minutes to 1 hour to complete your assessment. And at times you may not be able to do some brief counseling to a situational crisis client that's needed, especially if you are managing a busy ER. And another thing, keeping a personal professional boundary is very important. You have to leave your client's problem behind when you leave work and have proper self-care to manage your own life and have grounding, because it's impossible to work in crisis if you are going through emotional issues yourself. And another challenge that I would bring up is the documentation. You have to be very careful about what you're documenting, because that's the only document you will have to defend yourself for the decisions you made that day if you ever end up in the court in future in case of a death or a suicide of a patient. You will not be able to say anything from your memory and you have to rely on your notes. So you do not want to write anything that will get you in trouble with the law. Thank you.
Thank you so much, Ajimol, for explaining the challenges. Next question, how can one prevent relapse and continue to be mentally healthy? This is for Sebastian. Yes.
Okay, so as we mentioned in my part of the presentation, mental health recovery is a journey. It's not just one cure, it's an ongoing journey for most people. It's a chronic condition, and people, some of the people will have to live with it for life. So a lot of things depend on relapse or no relapse. So family support, financial support, patient's physical well-being, and ongoing consultation with the psychiatrist or the team or the community members. Those are all very important to keep the patient going, mentally healthy. And so those inherent elements of supports continue to help keep patient going. And the other part is the medication compliance. One of the big challenges with mental health is as we all know, if we have stomach aches, tummy hurts, exactly when it started and how it started, what kind of pain, morning, evening, or intense excruciating. We are able to pinpoint it very correctly and tell the doctor. But when your mind is affected, that process information, it is very difficult to see if the patient is sick for, so everybody else will know that they are sick, but the patient may not know they are sick. So it becomes very important for them to be medically compliant. I'm not saying people should live on pills. If something is not working, talk to the doctor before they make the treatment decisions by themselves. So it's a combination of multiple things that makes patient mentally healthy and not to relapse.
Thank you so much, Joe Sebastian, for your response. Next question is for Augusti Matthew. How do we access community mental health services?
Yeah, this is a very relevant question, how we access to these programs we talked about. Since I'm working in Toronto, let me give you how we do that. We have a centralized application center, which is called the Access Point. Online, we can give the application, send this application to this place. They coordinate the application. In the application, they ask for what services you need, which program like ANC team, housing, or case management, or drug and alcohol abuse rehabilitation program. So once they receive that application, they will coordinate this referral and forward our application to appropriate agencies, and you will be contacted. In the same way, you may have your own area, your own region. There are agencies doing the same referral services. You may have to find that. The second way of getting access to these programs, every mental health agencies, they have intake department. You could call directly and make the application and referral for yourself. And another way you can do is, if you have family doctor, any professionals working with you, they will be aware of community resources. They will be able to make referrals for you. And also, if the individual is in the hospital, the best person to contact is social workers. They know all the community resources appropriate for an individual. These are the ways we can get access to this program.
Thank you so much. If you would like to turn on your video to appreciate the presenters, if you wish to, you're welcome to do so. Just seeing if we do have any more questions from anyone else. Feel free to raise your concerns or questions if you have any, or you can email it to our MASWO Gmail, that is maswocanada@gmail.com.
Somebody had asked, so they want a case study for inpatient session. I don't know if it was inpatient or.
Yeah, I also noticed that, and not pretty sure about what exactly.
I don't know if the speaker is here on.
Harish, if you are still there, you can ask the question directly.
I think he's not in. If you want, you can conclude.
Sure, this is gone? Okay.
It's gone.
Okay.
Yeah.
If anybody would like to turn on their video and say thank you to the presenters, it's the time to say a big thank you to our presenters. I think everybody is hiding.
Thank you so much.
Thank you very much, speakers. That was a great presentation. I think this will help me. Basically, I'm as a social worker working in community, especially in the mental health settings. This was great inputs. I've been working 6 years, but I've learned new things, and this is a great opportunity. Part of this being as an organizer, also as a listener. So I really appreciate the speakers and Jaya for doing the coordination, and thank you so much.
Thank you, Alan. There was a question from Shubha asking if hoping that she will get a copy of the slides, and it was a great presentation by the awesome speakers. That is the comment she has mentioned.
Yeah, I will be giving out the slides.
Yeah.
Okay.
If anyone, they can give us a friendly reminder as an email to maswo@gmail.com.
Okay.
And then we can send that.
Sure.
And, we will be uploading this session to our YouTube channel, MASWO Canada, so you can watch the session there.
Thank you so much, presenters. It was awesome.
You're welcome.
Okay.
Thanks, sir.
Thank you. Thank you, everyone.
Okay, if you want to turn
Thank
the
you.
and then we can
Organizing. I know there is put hours and hours of work by so many of you. Hats off to all of you. It's amazing what you guys have done. We just did what you guys asked to, but all the work was done background by all of you guys. I know that.
But it was your precious time, like, you know, thank you so much.
Thank you.
Okay,
Thanks to all of you and all the presenters, including myself, with that good job.
We can't see you, Manoj.
I don't know, there is something problem with my computer now again. The internet is playing up now. Can you hear me?
Yes.
Yeah, we can hear you.
Thank God, that is after the presentation anyway.
Anyway, that is it.
Yeah, thank you everyone. The presentation was outstanding. Thank you so much.